Okay, great. First of all, I would like to thank Dr. Ahmed and the Fuad Group for giving me this opportunity to present or to give small talk about one of the important medical emergency topic as Team A or thrombotic microangiopathy. So we will talk briefly about the general approach to diagnose and the management. So Bismillah. First, we will talk about the definition of the Team A. It is a group of disorder characterized by microangiopathic hemolytic anemia, MAHA, plus thrombocytopenia and microthrombi that leading to ischemic tissue injury to a different tissues. Most of them are the kidney, sometimes are the brain also. So how are the Team A are classified? Usually we have a primary and secondary forms. The primary form of Team A is TTB and HUS, which is occur spontaneously without associated or underlying cause. The secondary form, usually it occur with context of a different cases as pregnancy, autoimmune disease, malignancy, sometimes after bone transplantation or use of certain medication. So regarding the incidence for the primary TTB and HUS, in TTB usually it happens in adults and about in 3 in each million case, and the incidence of the HUS usually it happens mostly in the children in about 3 of each 100,000 population. So it's a rare disease, but it's an emergency. So first of all, we will talk about the thrombotic thrombocytopenia purpura. It's broadly defined as thrombotic microangiopathy, which is occur in the context of severe ADAM-TS3 deficiency. ADAM-TS13 is a normal enzyme in plasma that eclipses the large forms of the coagulation protein Van-Willebrand factor into a smaller functional subunits. So the acquired form of TTB also it is thought to be due to an autoantibody against ADAM-TS13. So we have a primary and the acquired form. The primary usually it happens as there is a deficiency in ADAM-TS13, but the acquired form is thought to be it's an autoantibodies that become against ADAM-TS13. In HUS or hemolytic uremic syndrome, it's a clinical syndrome characterized by progressive kidney failure that associated with microangiopathy, hemolytic anemia, and thrombocytopenia. HUS, it's thought to be that one of the most common cause of acute kidney injury in children, and it's increasingly recognized in adults. Regarding the hemolytic uremic syndrome, also we can it has a two main categories depending on whether it's associated with Shiga toxins or not. So the first type is the typical or Shiga toxin associated hemolytic uremic syndrome. It's usually, as we mentioned, it's associated with Shiga syndrome. It's usually epidemic disease, and it largely affects children that younger than 2 to 3 years, and often result in diarrhea and acute kidney injury. Acute kidney injury usually it happens 55 to 75% of the patient, but they have a favorable prognosis. And as many as 70 to 80% of the patient are recovered their kidney function. Regarding the diarrhea, 1/4 of the patient they may present without diarrhea. Usually, the Shiga toxin related HUS or typical HUS, it's found in Asia and Africa. It's usually associated with the special, Shiga dysentery serotype. It's called 1, serotype 1. In North America and Western Europe, it's found to be 70% of Shiga toxin HUS cases secondary to E. coli serotype O157H7. And there is another E. coli serotype in black. It could be also associated with or lead to dysentery that may cause HUS, like O111 H8 and O103 H2. The other type of the HUS is a typical or non-Shiga toxin associated HUS, and this is the old name. The new name, it's called now complement-mediated thrombotic microangiopathy. So this is less common than the Shiga toxin. It accounts only for 5 to 10% of the all cases, but it's usually resulted from, as we said, this complement mediated with the infection of non-Shiga producing bacteria. It may occur at all age, but it's most frequently happen in adults. Not like the first type, which is happen mostly in the children, and usually occur without diarrhea. It can occur in sporadic. Also, there is some cases that can occur in families and sporadic cases. The familial form of atypical HUS or complement-mediated HUS usually associated with the genetic abnormalities of the complement regulatory protein, the third pathway of the complement activation pathway. So overall, patients with non-Shiga toxin or atypical HUS, usually they have, unfortunately, poor outcome with as many as of them, 50% of the cases, they end with end-stage renal disease that they require hemodialysis or irreversible brain damage. And up to 25 of the patients, they may die during the acute phase, especially if the diagnosis was made late. So how will we diagnose TMA? Usually the TMA is a clinical and pathological diagnosis. Usually when we have a case that presented with thrombocytopenia, anemia, and hemolysis anemia with the schistocyte in peripheral blood film, we have to suspect TMA, and we put it to one of our top differential diagnoses. And usually we, when we start, as we know by history, and we may get some clue from the history as the patient if he was in an endemic area with which is now to be Shiga toxins. They may presented with abdominal pain, especially dysentery, vomiting, and fever, and or they may presented with the usual presentation of anemia and acute kidney injury as lower limb swelling, shortness of breath, or abellar discoloration. And the neurological symptoms also is important, as the confusion, seizures, or may presented with a stroke in an elderly patient. So for the TTP and atypical HUS, unfortunately, most of the patients they didn't present with full picture of the disease as symptoms and signs. 5% only of the patients they may present with the whole picture: thrombocytopenia, neurological impairment, renal impairment, fever, and hemolytic anemia. So when we have, as we mentioned before, the first two criteria, thrombocytopenia and hemolytic anemia and schistocyte and peripheral blood film, we can consider it as TMA, and we can initiate the treatment. Since the early mortality is very high, it may reach even up to 50% if it's not diagnosed in the first 24 hours. So this is slides of the peripheral blood film that show schistocyte. And we can ask the lab immediately when the patient in ER if they can give us a preliminary report if there is a schistocyte in the peripheral blood film or not. So what is the initial treatment for TMA? So as we mentioned, it's an emergency cases with high mortality rate. The mainline treatment or the mainstay treatment is plasma exchange. With plasma exchange, mortality can be reduced to 20% only. And once when TTP suspected, plasma exchange should be initiated immediately. Plasma exchange, as we know, it's a procedure which the plasma from the patient is removed and replaced with fresh donor plasma by use of an apheresis machine. And if it was not available in the hospital or the facility that we are working on, we may use plasma infusion. Can be administrated while we are waiting for plasma exchange. And if we don't have the two, and the facility don't have the two, the plasma exchange and the plasma infusion, we have to transfer the patient to a facility that can provide it as soon as possible. And regarding the plasma exchange and the plasma infusion, there is one Canadian randomized trial study was done, which it showed that the improvement response for the plasma exchange and reducing the mortality about 3.9% compared with the plasma infusion. So the plasma exchange, it has a higher percent reduced mortality and improvement to the response rather than the plasma infusion. So a clinician should avoid the treatment delay and misdiagnosis by not waiting the treatment decision, and they are waiting the result of ADAM TS13 testing. The second line of the treatment, we may use also folic acid, as this patient has hemolysis and they may also they got folate depletion. The platelet transfusion should be only reserved for the patient with serious bleeding related to TMA, because this the platelet transfusion may be also associated with decreased risk of thrombosis. Corticosteroids, usually it's added to the plasma exchange as a part of initial therapy. Usually we start with prednisolone 1 milligram per kg orally, followed by a rapid taper over 3 to 4 weeks once a normal platelet count has been achieved. Also, we may use high doses if the patient has more severe disease or they have the lack of response in the first 1 or 2 days of their presentation. We usually monitor the response by platelet count and by hemolysis marker and the clinical symptoms of the patient. Some clinicians, they use an antiplatelet, but it's a controversial that regarding they use it to decrease the risk of a thromboembolic event with TMA, but it's a controversial and it can be used as a secondary prevention. In patients with platelet count greater than 50 million. Regarding the HUS related shigatoxin, usually it's improved with the supportive care as hydration and red blood cells transfusion. Antimicrobial treatment may worsen the disease, especially with some strain, bacterial strain of E. coli, and antibiotic classes will do, it may worsen the prognosis of the disease. Plasma exchange, usually in typical HUS or shigatoxin HUS, is rarely needed. But in a typical HUS or complement-mediated HUS, plasma exchange, it should be administered because in the patient, for the patient initial presentation, it's difficult to distinguish between a typical HUS and TTP. So we can start plasma exchange and till the ADAM TS13 result appears, so we can differentiate it between TTP. We can consider the plasma exchange. So the diagnosis of a typical HUS should be considered in patients with substantial renal impairment who do not respond to plasma exchange and who do not have severe ADAM TS13 deficiency. For those patients, we can use eculizumab, which is a monoclonal antibody against the terminal complement component C5. we should consider it when we reach to the diagnosis of atypical HUS. So when you have the result of ADAMTS13 deficiency with ongoing renal impairment, regardless of the plasma exchange and the steroid, we have to consider an atypical HUS and we use eculizumab. We have we will just give a small talk about the refractory and relapsed thrombotic microangiopathy. So refractory thrombotic microangiopathy is generally defined as the lack of improvement of platelet count and persistent hemolysis, or lack of symptoms improvement, or if there is a new neurological signs after 5 to 7 days of plasma exchange started. This is, we may consider it as refractory TTB or TMA. And regarding the relapsed one, is defined as a disease recurrence after the remission, and usually happen 30 days after the last plasma exchange of the treatment. The evidence from retrospective studies suggests that relapsed or refractory TTB can be managed successfully by increasing the intensity and frequency of plasma exchange, and also by increasing the doses of immunosuppressant therapy, including the corticosteroid. Rituximab also, if the patient still they have relapsed events, we can add it. It shows some effective response against the refractory TTB. Even there is some investigators, they use it in their studies as an initial therapy. We have another types of treatment for the refractory and relapsed TTB as cyclosporin, cyclophosphamide, and N-acetylcysteine. And splenectomy, it showed to be reduce the rate of relapse in patients with recurrent TTB. And for patients with relapsed or refractory atypical HUS who required renal transplantation, a preemptive use of eculizumab, it show that it improve the post-transplantation outcomes even, and the attacks of atypical the complement to transplanted kidneys. And the combined liver and kidney transplantation can restore renal function and increase the level of complements regulatory protein that are produced by the liver. And the patient with atypical or refractory atypical HUS should be re-evaluated to ensure that secondary causes are not missed. And if you have a case with recurrent atypical HUS or a recurrent complement mediated HUS, we should also go back to the history and the labs, and we have to look for another secondary causes that could be missed as a cause of the atypical HUS. So last thing, the key points of our small talk about the TMA, it's a hematological emergency that requires urgent intervention, since the full picture of signs and symptoms, which is thrombocytopenia, schistocyte or hemolytic anemia, neurological impairment, renal impairment, and fever, it only happen in 5% of the cases as an initial presentation. So when we have the first two criteria, thrombocytopenia and hemolytic anemia, and schistocyte and peripheral blood film, we should suspect it and we start the treatment immediately. As we know, the mortality rate with the 24 and 20 in the first 24 hours is very high. It may reach to 90%. Testing for severe ADAMTS13 deficiency should not delay the treatment, and usually we prefer to send the lab for ADAMTS13 and complements before starting of the plasma exchange, so it will not affect on the result of the ADAMTS13 and complements level. Refractory or relapsed TTB require intensification of plasma exchange treatment and immunosuppressant medications. This is my references, and thank you. If you have any questions.
Thank you very much, Dr. Ibrahim. Very nice talk about the thromboembolic, and you tackle the theoretical as well as the practical part. Really nice